Yeah, hello, Dr. Chanchal.
Hello. Yes.
Yes, sir. So your voice is clear. Yeah. You can just go little further from your laptop so that the video will be better. Yeah,
Is
and
that
you can just
okay?
tilt the. Yes, sir. It is okay, but if you can tilt your, laptop. Yeah, yeah. So that your half portion should be visible to the audience, and you can remove the black bag there.
Yeah.
That is the on your right side. One black bag is there.
Sorry. Black
Yeah.
bag. Yeah. Yeah.
Yeah.
Yeah. Okay. Is that fine?
That is fine.
Am I audible clearly?
Yes, sir. You are
Am I
audible
audible
clearly.
clearly?
Yes, you are audible clearly.
Yeah. So I'll just
Share the screen now.
okay. I'll just share the screen.
Yeah.
Hello.
Hello, you can share the screen.
Yeah. 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 One second.
Yeah, so screen is coming here.
Is it full screen now?
Yeah, it is full screen. Can you toggle between the keys so that it is moving front and back?
Yeah.
Yeah.
Is it moving?
Yeah, it is moving. No, now, yeah, it is
Fine.
moving. Yes, moving. So in case, sometimes what happens in full screen, it gets stuck, right? Sometimes it happens. So in
Mhm.
that case, again, you have to just
Mhm.
minimize it, and in the normal PowerPoint mode, you can run it in that adverse condition.
Okay.
Okay. So,
We'll have to stop sharing and then again we'll have to reshare. That's what, no?
yeah, in that case, if we will just stuck in that case. Okay.
Yeah. Yeah. Okay.
Yes. So now I'm admitting everyone because few people are waiting. Is it okay?
Okay.
Okay.
Yeah. Fine.
Yeah. Hello, everyone. We will start the session by 12. A very good afternoon, everyone. I welcome you all on behalf of Ankura Hospital for Women and Children. As an initiative for knowledge sharing and medical discussion from Ankura Hospital for Women and Children, which is solely dedicated to comprehensive women care and comprehensive child super specialties, we have Ankura Knowledge Hub as knowledge sharing platform. Today we have an interesting topic: basics of parenteral nutrition in neonates. It's our pleasure to have speaker Dr. Chanchal Kumar, who has done MD in pediatrics from PGIMER, Chandigarh, and DM in neonatology from Jipmer, Pondicherry. He is recipient of V. Bala Gopal Raju Award for the best DM thesis in year 2020, and Dr. Chanchal has awarded the gold medal for outstanding paper NeoCo 2020, and he has 5 research publications and he has contributed to protocol book chapters. Currently, he is working as consultant neonatologist in Ankura Hospital for Women and Children. I welcome Dr. Chanchal Kumar as our speaker on this virtual platform to take the session further. Sir?
Yeah, thank you for the introduction, and a very good morning to all the participants who are attending. So the topic of today's discussion is basics of parental nutrition. Yeah. So to start the discussion, I'll just quote the famous study from Ankura et al. Group, and this was published in Pediatrics in 2006. You can see that they actually studied the impact of nutrition on the neurodevelopmental outcome of the infants. And this is the table which is showing the result. You can see that the outcome they assessed at 18 to 20 months of corrected age. And you can see that as the weight gain in gram per kg per day is increasing from 12 uh, to 21 gram per kg per day, you can see that the incidence of cerebral palsy is reducing. And similarly, the other parameters like mental developmental index score less than 70, or psychosocial developmental index score less than 70, or neurodevelopmental impairment, or being its rehospitalization. So all these parameters are actually on improving trend as the weight gain in gram per kg per day progresses from a median of 12 gram per kg per day to 21 gram per kg per day. So we know that there is a good impact of the nutrition on the neurodevelopmental outcome at around 18 to 20 months of corrected age. So the most important part is early enteral nutrition, and now we have enough evidence on early enteral nutrition and its impact on the neurodevelopmental outcome at 18 to 24 months of age. So I'm going to talk about a different scenario when we can't feed the baby. So the reasons, there are various reasons
Pediatric హాస్పిటల్‌లో చేసినప్పుడు మంచిగుండేనా మధులిక?
for we can't feed the baby.
All participant, keep yourself in mute mode.
Yeah. So so there are various reasons why we can't feed the baby. This could be because of extreme prematurity. Either this can be because of critical illness, or there are any surgical indications like congenital gut disorders. So in those cases, we can't feed the baby, and we'll have to depend upon the parenteral nutrition. So there comes the role of total parenteral nutrition. So if you see the literature review, that for the total parental nutrition, this was totally practice based till now, like until recently when we got two recent guidelines from SPEG 2018 and NICE 2020 guidelines. So now we have at least two guidelines so that which can help us giving total parental nutrition. If you look at the Cochrane review also, there are few Cochrane reviews only on the total parental nutrition, around 6 to 7 Cochrane reviews. And in those reviews also, the evidence is kind of inconclusive. So they are actually not recommending the practice guidelines based on those limited evidence. So so my present talk is based on these two recent guidelines on total parental nutrition in neonates, which is SPEG 2018 and NICE 2020 guidelines. So when we talk about total parental nutrition, there are few questions which come to our minds. So what are the basic principles of total parental nutrition? When should we start total parental nutrition? Who are the babies in whom we can start total parental nutrition? What are the various components of total parental nutrition and the various formulations available in the market? Then how to prepare a TPN, and do we have to monitor labs when we start total parental nutrition? And last but not least, the various complications and its management. So I'd like to start with the first poll question. So can we have the poll question 1? Yeah, you can see the poll question 1. So all neonates with what gestational age to be started on TPN? So we have 4 options: less than 28 weeks, less than 26 weeks, less than 30 weeks, and less than 31 weeks. So we have some 10 seconds. Yeah, I think it's not moving now, so we can end the poll. Okay, so here we can see the mixed results. So around 50% of you have responded that it should be less than 28 weeks. Few of you have responded it should be less than 31 weeks. So let's see what the guidelines say. So if you look at the NICE 2020 guidelines, this is for TPN for all the neonates who are less than 31 weeks of gestation. So basically, less than 31 weeks of gestation, we have to start TPN for all the neonates. If the neonate is more than 31 weeks, then you have certain scenarios, like if there is no enteral feeding progress in the first 72 hours after birth, or there is some congenital gut disorders like congenital diaphragmatic hernia, or this could be omphalocele gastroschisis, these kind of conditions. And if there is some critical illness like sepsis. So suppose you have started enteral feeding and because of some reasons actually you have to stop enteral feeding, then what the guidelines say about that scenario. So in case of preterm, if you have stopped enteral feeding and this is unlikely to be restarted in next 48 hours, then you have to consider total parental nutrition. In case of term baby, suppose you have stopped enteral feeding because of some reason, and this is unlikely to be restarted in next 72 hours, then you have to consider total parental nutrition. So when to start, like how early we can start total parental nutrition? So once you have stabilized the baby and you have secured the lines. So as per NICE 2020 guidelines, they recommend we have to start a total parental nutrition as soon as possible if indicated, maximum within 8 hours of birth. So you have 8 hours time. So in this period, you can start as early as 8 hours, within 8 hours after birth. So next the question is like what excess we have to use for administration of total parenteral nutrition. So central venous access is preferred option, but peripheral access can also be used for like certain scenarios when you have when there is delay in starting total parenteral nutrition because of getting central venous access, or you are anticipating that there is just short-term use of total parenteral nutrition that is less than 5 days. And if the central venous access is impractical, then you can start with peripheral access. So what is the principle behind this peripheral access and central venous access, the administration of total parenteral nutrition? We all know that there is a certain upper limit of osmolality, which we can osmolality of the solution, which we can administer by peripheral venous access. So total parenteral nutrition has osmolality way beyond, like more than 900 milliosmol per kg. So that one is like that's why we have to prefer central venous access, not peripheral venous access, but it can be, and there are chances of ectasis and NGD. Intralipid solution has osmolality roughly around 300 milliosmol per kg. So this can be given by peripheral access also, even for long term also, so not a problem. If you have a problem with the access of central venous access, so when should we consider surgical insertion of a central venous catheter? So if non-surgical insertion is not feasible, or you and you are anticipating the long-term use of total parenteral nutrition, like certain congenital gut disorders, including diaphragmatic hernia or some bowel malformation, where you have to use total parenteral nutrition beyond 2 to 4 weeks, then you can consider the surgical insertion of central venous catheter. This is as per NICE 2020 guidelines. So this slide shows the various composition of energy, and this is from NICE 2020 as well as the second guide 2018 guidelines. So the mixture, the composition of the energy should be distributed among carbohydrate, fat, and protein. So carbohydrate should be the major source of energy, around 50 to 60%. Fat should be around 30 to 40%, and protein should be around 10 to 15%. So this composition is based upon the estimated energy requirement of the preterm. We all know that the resting metabolic rate of preterm baby is roughly around 40 to 50 kilocalorie per kg per day. So energy expenditure is roughly around 40 to 60 kilocalorie per kg per day. And energy used in excretion is around 15 kilocalorie per kg per day. So energy intake should be around 90 to 120 kilocalorie per kg per day. And we should note that the internal nutrition calorie intake is roughly around 30 kilocalorie per kg per day more than parenteral nutrition, because it avoids this energy used for excretion. So roughly 30 kilocalorie per kg per day more than total parenteral nutrition. So now, since we are talking about total parenteral nutrition, so our energy intake should be roughly around 30 kilocalorie per kg per day, less than internal nutrition. So let's see the guidelines recommendations. So as per NICE 2020 guidelines, if you are starting TPN within first 4 days after birth, then you start at 40 to 60 kilocalorie per kg per day and gradually increase to 75 to 120 kilocalorie per kg per day. But if you are starting beyond 4 days after birth, then you can directly start at a range of around 75 to 120 kilocalorie per kg per day. The second guidelines recommendations are also kind of similar to NICE guidelines. So on day one, they're recommending to start at around 45 to 55 kilocalorie per kg per day and gradually increase to 90 to 120 kilocalorie per kg per day. And as per their recommendation, the target weight gain should be around 70 to 20 gram per kg per day. So what are the principles of energy intake? So we all know that if we provide sufficient energy and nitrogen, then it will prevent the catabolism, and there will be positive nitrogen balance. So in a preterm, the energy cost of growth is around 5 kilocalorie per gram, which is around 15 gram per kg. And energy expenditure, as we saw in the previous table, is around 50 to 60 kilocalorie per kg per day. So to support normal growth during parenteral nutrition, we need around 90 to 120 kilocalorie per kg per day. And as I told earlier, so parenteral energy requirement is less than parenteral nutrition energy requirement roughly by around 30 kilocalorie per kg per day. So what happens if we don't provide enough non-protein energy? So if we don't provide enough non-protein energy, then there will be catabolism of amino acid just to balance the total energy requirement. So we have to provide protein energy in the ratio of 3 to 4 gram per 100 kilocalorie of energy, non-protein energy, to promote protein excretion. And there should be balance between carbohydrates and fats to prevent excessive fat deposition and excessive production of carbon dioxide. We all know that the respiratory quotient of carbohydrate is roughly around 1, and for fat it's around 0.7. So there is excessive carbon dioxide production in the metabolism of carbohydrate as compared to the fat metabolism. And so we have to maintain the balance between carbohydrate and fat in the composition of total parenteral nutrition. Coming to glucose, so glucose is glucose. So sometimes overfeeding symptoms also will be there. So what are the recommendations of NICE 2020 guidelines for the glucose? So if you are starting within first 4 days after birth, then you start at 4 to 6 milligram per kg per minute. This is called as glucose infusion rate. So you start at 4 to 6 milligram per kg per minute and gradually increase to 6 to 11 milligram per kg per minute in the maintenance phase. But if you are starting beyond 4 days after birth, then you can directly start at in the range of 6 to 11 milligram per kg per minute. Coming to protein, so preterm babies lose around 1.5 gram per kg per day of their protein if you just provide glucose alone without any amino acid. Term babies lose around 0.7 gram per kg per day. So if you provide amino acid at around 1.1 to 2.3 gram per kg per day with a calorie intake of around 30 to 50 kilocalorie per kg per day, then there will be a negative to neutral protein balance. And various studies have shown that there is no correlation between amino acid intake and blood urea nitrogen level. The neonatal amino acid solutions are actually different from adult amino acid solution preparation, because neonatal amino acid solution contains essential amino acids and some conditional essential amino acids. Cysteine is one important amino acid because it improves nitrogen retention and it improves solubility of calcium and phosphorus also. So we have to keep in mind that we have to achieve nitrogen retention similar to the in utero rates without causing any metabolic disturbance. So early parenteral nutrition amino acid with calorie intake of at least 50 kilocalorie per kg will result in positive nitrogen balance. Proteins are building blocks, so it should contain essential amino acid and conditionally essential amino acid, including cysteine, tyrosine, glutamine, and taurine. There should not be excess of glycine and methionine. That's why this is different from adult amino acid preparation. There should not be sorbitol, and there are two formulations available: 6% and 10%. Most commonly being used is 10% amino acid solution. There are certain special amino acids also, like glutamine, which is like a major energy substrate for small intestinal mucosa, and various studies have shown that it reduces fat infiltration of liver. Some effect on reduction of NEC incidence as well as sepsis. Taurine also, some studies have shown that it reduces cholestasis, and cysteine, as we saw in the previous slide, it lowers pH of the final solution, and it improves the solubility of calcium and phosphorus. We have one Cochrane systematic review on cysteine supplementation, and they have concluded that it improves nitrogen balance. However, there is no effect on growth. There is no effect on long-term major morbidities, including bronchopulmonary dysplasia or mortality or interventricular hemorrhage, retinopathy of prematurity, NEC, PVL. And there is insufficient evidence to assess the risk of metabolic acidosis. What about early versus late amino acid? So we have amino acid administration in TPN. So we have one Cochrane systematic review on this question. So late administration of amino acid means beyond 4 days of after birth. So in this review, they have documented that although there is positive nitrogen balance in early amino acid administration group, but the acid-based status and the ammonia level were actually not different, and there was no benefit on the major morbidities as well as mortality. So mortality as well as early and late growth and neurodevelopmental impairment. So they have concluded that there is insufficient evidence to guide practice for early versus late amino acid depletion. We have one Indian study by Umesh Vedya group. So in this, they have compared aggressive amino acid administration versus standard amino acid administration. Aggressive amino acid administration means they started 3 gram per kg per day of amino acid on day 1 of life, and the standard would be around 1 to 2 gram per kg per day. So in this RCT also we can see that apart from this calorie received in first week of life and calories provided by the parenteral nutrition, other parameters are actually not different. So we don't have any conclusive evidence for aggressive amino acid. Aggressive means like beyond 2 gram per kg per day of amino acid administration from day 1 of life. So let's see the guidelines recommendation according to NICE 2020 guidelines. So they say that for preterm babies, if you are starting within first 4 days after birth, then you start at 1.5 to 2 gram per kg per day and gradually increase to 3 to 4 gram per kg per day. So we can see that they are also not going very aggressively. So it's around 1.5 to 2 gram per kg per day on day 1. If you are starting beyond 4 days after birth, then you give a range of around 3 to 4 gram per kg per day. For term babies, it's somewhat different. So if you start within first 4 days after birth, then you start at 1 to 2 gram per kg per day and gradually increase to 2.5 to 3 gram per kg per day. So we can see that the protein requirement is more in preterm babies as compared to term babies. So the upper limit is around 3 gram per kg per day for term babies. If you are starting beyond 4 days after birth, then you can directly start at 2.5 to 3 gram per kg per day. So next one is lipid, and we have one second poll question on lipid. So question says, which is the ideal lipid emulsion to be used in total parenteral nutrition? Is it soya based, fish oil based, or composite lipid emulsion? I think 60% of them have voted, so we can end the poll. Okay, so we can see a mixed response. So around 30% of you have responded, have chosen soya-based preparation, and around half of you have chosen composite lipid emulsion. So let's see the guidelines recommendations. So according to NICE 2020 guidelines, for both preterm and term babies, if you are starting within first 4 days after birth, you start at 1 to 2 gram per kg per day and gradually increase to 3 to 4 gram per kg per day in maintenance phase. If you're starting beyond 4 days after birth, then you give a range of around 3 to 4 gram per kg per day. This is for the amount of lipid. So various studies have shown that the ratio between free fatty acid and albumin should be greater than 6:1. The lipid emulsion contains neutral triglyceride, which is derived from soybean oil, safflower oil, or fish oil based. Then there is egg yolk for the emulsification, glycerine to adjust the tonicity and to maintain the tonicity roughly around 300 milliosmol per kg. use of 20% lipid emulsion is preferable as compared to 10% lipid emulsion solution, because it causes less hypertriglyceridemia, hypercholesterolemia, and hyperphospholipidemia. We'll see the mechanism. So we can see that this is the interlipid molecule. So there is a core of triglyceride and surrounded by phospholipid molecules. So this is the metabolism of this one is like this is deacidified into free fatty acid, and which is being used for energy source, and it is deacidified also and getting stored. The remnant particles will be converted to lipoprotein X, and this happens more with 10% lipid emulsion as compared to 20% lipid emulsion. So there will be lesser clearance of triglyceride, and there could be hypertriglyceridemia. So that's why 20% emulsion is preferred as compared to 10% lipid emulsion. So let's see the various the composition of various lipid emulsion available. So if you see the soya-based lipid emulsion, this soya-based is actually rich in essential fatty acid, including linoleic and linolenic acid, but it is deficient in this omega-3 fatty acids, including icosahexaenoic acid and docosahexaenoic acid. But if you see fish oil, this is deficient in essential fatty acid, but rich in the omega-3 fatty acid, which are icosahexaenoic and docosahexaenoic acid. If you see the composite lipid, the SMOF is one kind of composite lipid emulsion, which is based on both soybean medium chain triglyceride oil, olive oil, and fish oil. So this is kind of mixture, and one kind of a composite lipid emulsion. So you can see that this provides adequate amount of essential fatty acids as well as omega-3 fatty acids. So that's why we can say that the composite lipid emulsion actually should be preferred as compared to soya-based or fish oil-based lipid emulsion. So we see some evidence also regarding fish oil-based lipid emulsion. So some of the studies have shown in this systematic review by Kotia et al. They have documented that fish oil-based lipid emulsion although it reduces cholestasis, but soya-based lipid oil emulsion actually reduces duration of respiratory support and mortality. But it's not conclusive evidence. There is some concern about lesser incidence of severe ROP and ROP requiring laser by using soya-based lipid emulsion as compared to fish oil-based lipid emulsion. So, but we don't have enough evidence. So, based on the guidelines, we can say that we have to use composite lipid emulsion, which will provide the adequate amount of essential fatty acid as well as omega-3 fatty acid. So let's see the composition of SMOF lipid. As I told, this is a mixture of soybean oil, medium chain triglyceride oil, olive oil, and fish oil. And we have just in this table, this has been compared with interlipid 20%. And you can see that osmolality is almost similar. But the ratio of omega-3 is to omega-6 amino acid is actually more in SMOF lipid as compared to intralipid. So this is good for good for brain and retina. And there are in some studies they have documented this has some anti-inflammatory properties also that which are helpful in sepsis, and probably it prevents liver damage also. So what about SPEC in 2018 guidelines on lipid administration? So they recommend we have to use the composite intralipid emulsion, and it is to be preferred over pure soya oil based lipid emulsion. The administration should be continuous infusion over 24 hours. So there should not be any interruption of the infusion of intralipid emulsion. It should be protected by light. The tubings and syringes should be protected by light to prevent photooxidation. Heparin, there is no routine, they have not recommended to use it routinely, although we know that heparin actually improves the it has antithrombotic effect, and it improves the activity of lipoprotein lipase. So it actually helps in clearance of triglyceride. But the routine use of heparin is not recommended as per these two guidelines. Similarly, for carnitine supplementation also, so carnitine actually helps in entry of fatty acid into the mitochondria, which actually is not required for medium chain triglyceride molecule. So, but for the routine supplementation of carnitine also, they are recommending the various studies have and the guidelines also they have recommended that if we are going to use TPN for beyond 4 weeks or in some preterm babies on individual basis, we can think of carnitine supplementation, but it should not be routine supplementation. Then the clearance of this triglyceride is actually the amount of lipid whatever we are administering in total parenteral nutrition, even at 3 gram per kg per day, it is less than the threshold of clearance of triglyceride. So actually it does not reduces the platelet count or disturbs the platelet function, or it does not displace albumin from the bilirubin molecule. So actually there are no increased incidence of thrombocytopenia or platelet dysfunction or hyperbilirubinemia with this dose of intralipid emulsion. However, if there is unexplained thrombocytopenia and you then you monitor triglyceride frequently, and if it goes beyond 200 and you don't have any other cause for thrombocytopenia, then you may reduce the dose of intralipid. This is as per SFAGN 2018 guidelines. So next is what should be the ratio of non-nitrogen to nitrogen. So as per NICE 2020 guidelines, they recommend we should use 20 to 30 kilocalorie of non-nitrogen energy per gram of amino acid. So this is also called as calorie nitrogen ratio. So 20 to 30 kilocalorie per gram of amino acid. And non-nitrogen energy, the composition of non-nitrogen energy, the carbohydrate should contribute roughly around 60 to 70%, and lipid should contribute around 25 to 40% of total non-nitrogen energy intake, as recommended by NICE 2020 guidelines. So next one is iron. So both guidelines have recommended that there should not be routine iron supplementation on TPN if the TPN administration is less than 28 days of life. But if the baby is requiring total parenteral nutrition beyond 28 days of life, then you have to monitor iron status, including ferritin level. And then if it's in deficient state, then you have to treat. Otherwise, you don't have to routinely administer iron in total parenteral nutrition. So what about calcium? So for both preterm and term babies, if you're as per NICE 2020 guidelines, if you're starting within first 48 hours after birth, then you start at 0.8 to 1 millimole per kg per day, which is roughly around, if you calculate, it will be roughly around 32 to 40 milligram per kg per day, and increase to maintenance range of around 60 to 80 milligram per kg per day. If you're starting beyond 48 hours after birth, then directly you can start at 60 to 80 milligram per kg per day, which is around 1.5 to 2 millimole per kg per day. This is similar in SPECN 2018 guidelines also. So next one is phosphorus. So as per NICE 2020 guidelines, this is for both the preterm and term babies. So if you are starting within first 48 hours after birth, then you start at around 30 milligram per kg per day, increase to around 60 milligram per kg per day. And if you are starting beyond 48 hours after birth, then directly you can start at 60 milligram per kg per day. This is almost similar in both the recent guidelines. As per, for calcium phosphate molar ratio, NICE guidelines and SPECN guidelines both are recommending to maintain less than 1, which is around roughly around 0.8 to 1 for both preterm and term babies. What about magnesium? So as per for both as per NICE 2020 guidelines, there is no dose recommendation, but they are recommending to start at outset. If you look at the SFAGN guidelines, so for both preterm and term babies, they are recommending to start at 0.1 to 2 millimole per kg per day. And for growing preterm, you have to continue at 0.2 to 0.3 millimole per kg per day. For multivitamins, there are no definite recommendation, but both the guidelines actually recommend to start at outset, and it should be mixed in lipid solution. And as per second guidelines, they usually recommend separate dose for preterm and term babies. But roughly, we start at around 1 ml per kg per day of multivitamin solution. Next one is trace elements. So similar to multivitamins, for trace elements also, there is no specific recommendation as per both these recent guidelines. But trace elements should be started usually after 2 weeks of life, when you are continuing TPN beyond 2 weeks of life. Zinc is the only trace element which is to be started from day one of life. So this slide shows various available preparations. So you can see that the disclaimer is I'm not endorsing any brand over here, but you can see the available formulations in the market. So amino acid solution is available in 6% and 10% formulation. Lipids 10% and 20%. So 20% is to be preferred, and we saw that composite lipid emulsion should be preferred. Especially if this is long-term use. So beyond 5 days, if you are going to use TPN, then please don't use soya oil-based interlipid emulsion. For glucose, the available preparations are 5%, 10%, 25%, and 50%. NaCl is available in 0.9% and 3% formulation. KCl is in 15% formulation. Calcium gluconate is 10% formulation, and magnesium sulfate is 50% formulation. The availability of trace elements actually is an issue, and anyway we don't have to start within first 2 weeks. Zinc is the only trace element which is required in first 2 weeks of life. So then next problem is like, what are the complications which we have to anticipate, and how we have to manage these complications. So I have just categorized these complications in three broad categories. One is metabolic complication. Second one is the complications related to catheter, and third one is general complications. So let's see one by one. So metabolic complications include hyperglycemia, hyperchloremic acidosis, metabolic bond is of preterm, abnormal amino acidogram, and hyperlipidemia. So these are metabolic complications. The other complications like catheter-related complications include infection, thrombosis, any tissue necrosis because of extravasation, pleural effusion, and sometimes pericardial tamponade if your the catheter tip is not in the position. General complications include cholestasis and gut mucosal atrophy, because you are not providing enteral nutrition in the early phase of life. So one major complication which is talked about mostly by various studies, it is TPN-induced cholestasis. This is also called as parenteral nutrition-associated liver dysfunction. So there are various risk factors which are enumerated by various studies, which actually contribute to the TPN-induced cholestasis. So these risk factors are prematurity, sepsis, any hemodynamic instability, and if the duration of parenteral nutrition is prolonged beyond 2 weeks, and if you are delaying enteral feeding because of various issues. So even if the baby is on TPN, and then you have to think of starting enteral feeding as early as possible, as the baby is able to tolerate enteral feeding. The earliest marker of this TPN-induced cholestasis is serum bile acid, and various studies have shown that phenobarbital and ursodeoxycholic acid actually have some role in reversal of TPN-induced cholestasis. So one comment about TPN-induced cholestasis. So if you use pure soy oil-based lipid emulsion, then there are more chances of TPN-induced cholestasis. The fish oil-based emulsion, although there are conflicting results whether it prevents TPN-induced cholestasis or not, but it helps in the reversal of TPN-induced cholestasis. So once you document cholestasis, then you have to change from soy oil-based lipid emulsion to composite lipid emulsion or fish oil-based lipid emulsion as per the availability. So next important complication is prevention of infection. So we have to take all utmost aseptic precautions during the preparation of parenteral nutrition. Laminar flow is actually to be used for the preparation, for the compounding of the solution. There should not be any compromise on the disposables. We have to train our staff how to prepare, how to take care of all the aseptic precautions, including aseptic non-touch technique. There should not be reuse of parenteral nutrition solution, and mostly we prepare for 24 hours. The solution should be prepared for 24 hours if the baby is on stable parenteral nutrition, like some congenital gut disorders. In that case, actually, this can be prepared for 48 hours also. There should not be any interruption of the venous line which is carrying parenteral nutrition. So there should be one dedicated line for parenteral nutrition, and we should not use that line for antibiotic administration or some other drug administration, including caffeine and other drugs. So one dedicated access for parenteral nutrition. Bacterial filter actually to be used for the amino acid tubing, not for intralipid tubing. So if it's actually, it increases the cost of total parenteral nutrition, but if it's available, then it should be used before the Y connection. In the amino acid tubing, and not the intralipid tubing. So various practical aspects we have to consider during preparation. So there are 3 steps of total parenteral nutrition preparation. First one is compounding, like how to prepare the solution, then the priming of the tubings, and then connecting to the infants. So for compounding, ideally we should have 2 persons for the compounding of the solution. Laminar flow, as I mentioned, should be used for the preparation. We have to take almost all utmost precautions, including aseptic non-touch technique. There should be surgical asepsis. As I told earlier also, we have to prepare solution mostly for 24 hours and in some cases for 48 hours. The timing of the preparation also should be decided based on it should be just prepared just before connecting to the patient. So whether you are preparing in the morning time or evening time, so you have to decide based on your unit policy, but it should be prepared just before connecting to the patient, and it should not be kept on room temperature for a long time before connecting to the patient. If there is any delay in connecting to the patient, then you have to store in refrigerator. So you don't have to keep in room temperature. So store in refrigerator. Next one is priming and connecting to the patient. So you have to prime the tubing and 3 way just to avoid air bubbles. Aluminum foil coating is required for prevention of photooxidation of the lipid solution. So lipid and MVI solution, which is actually in the same tubing. So we have to protect the syringe as well as tubing of the interlipid emulsion from the light. Then taking following aseptic non-touch technique for connecting to the patient. Don't interrupt the line for medication or any sampling. We have to do this frequent check of cannula and PICC line site. If there is any extravasation or any suspicion of displacement or any tissue necrosis, then we'll have to stop the total parenteral nutrition administration. And change of the tubing should be every 24 hours. So whenever we are preparing that same tubing, we can use for 24 hours. We don't have to change in between. So next thing is monitoring of the infant when the infant is on total parenteral nutrition. So what are all parameters we have to monitor and how frequently, whether it is different in initial phase from maintenance phase. So let's see. So this is based on both recent guidelines, NICE 2020 and SPECN 2018 guidelines. So for blood pH, potassium, chloride, and calcium, they are recommending to monitor daily in the initial phase, and if the baby is on stable TPN, then in maintenance phase we can monitor twice weekly. For triglyceride also, since we are increasing the lipid emulsion amount, so in the initial phase it should be checked daily, and then weekly is enough. Phosphate also similarly daily in the initial phase and weekly in the maintenance phase. Liver this LFT, we should have one baseline LFT before starting TPN, and then weekly LFT monitoring is adequate, is enough. As I told earlier, for iron is not routinely supplemented in total parenteral nutrition. And once your TPN administration is going beyond 28 days of life, then you have to monitor for iron ferritin level and transferrin level if this is going beyond 28 days. However, we have to make a note that these parameters are to be monitored more frequently if the levels are outside the normal. Suppose your triglyceride is out of your normal range, then you will have to monitor more frequently, not as per this table. Okay, or there are some clinical concerns, like suppose in case of sepsis, you think that there is a decreased activity of lipoprotein lipase enzyme, and there could be decreased triglyceride clearance. So then, in that case, you have to monitor somewhat more frequently as compared to this table. So next one is when to stop total parenteral nutrition. So as per NICE 2020 guidelines, they recommend to consider these factors when you have to consider when you have to think of stopping of total parenteral nutrition. So there should be a tolerance to internal feeds. Amount of internal nutrition should be adequate for the energy requirement. There should be likely benefit of nutritional intake versus the risk of sepsis. And sometimes, and you have to consider individual baby's requirement also, like long-term need in case of surgical conditions like short bowel syndrome. So roughly they have recommended you have to stop within 24 hours once enteral feed is attained at around 140 to 150 ml per kg per day in less than 28 weeks infant. If infant is more than 28 weeks, then 120 to 140 ml per kg per day we can stop, consider stop. So learning points, my learning points would be start TPN as early as possible, maximum within 8 hours if indicated. Monitoring is crucial during total parenteral nutrition. You have to follow utmost aseptic precaution, including aseptic non-touch technique. And written unit-based protocol is always helpful because it will prevent all the calculation errors as well as various complications which we have just discussed. So ideally, we should have one written unit-based protocol, and which is to be followed universally in the unit. Thank you for the patient listening. So I'd be happy to take questions if any.
Yeah, so we have got one question here for you.
Yeah.
What is the option when TPN access cannot be? What is the option when TPN access is almost impossible and difficult?
Yeah. So as I mentioned in the slide also, as per NICE 2020 guidelines, they recommend that if the central access is totally impractical, then you can think of considering peripheral venous access for the short duration. And then if this is really indicated, like this is extreme preterm, less than 31 weeks baby, or some congenital gut disorders, in those cases, this is really indicated, then you have to think of surgical insertion of central venous catheter. For the time being, meanwhile, you can continue with peripheral venous access, although there are chances of extravasation because of high osmolality through peripheral venous access, but you have to monitor for more frequently, and you have to think of surgical insertion of central venous catheter.
So request all delegates, if you have any question, you can just post in the chat group. So I'm unable to find any more questions now. I think all the parts are covered by you, Dr. Chanchal. So thank you, Dr. Chanchal, for lucid presentation. And Ankura Hospital for Women and Children thank all delegates to attend the webinar and for their patience and time.
Thank you all.
Okay,
Thank you. I'd like
thank
to
you,
thank the
everyone.
organizer for wonderful organization, and thank you to all the participants who attended this session. Thank you.
Thank you, everyone. I'm ending the session for everyone.